why is this important? I think most of us in this room know the traditional and emerging risk factors for cardiovascular disease. I think that the thing that we sometimes forget is the socioeconomic contributions. So when we look at this map by the CDC and see these clusters of heart disease death rates, we can see that there are areas that are darker red that have been disproportionately affected. And unfortunately, when we overlay maps of poverty, they match up quite nicely. And when we think about one step further, the status of women and poverty in this country, unfortunately, we know that the majority of single-headed households for women are often in poverty. And we can look at the map by the Women's Law Review at the bottom, and it again overlays with the death rate map. And I think that it's no surprise to any of us that 380,000 deaths can be attributed to coronary disease in this country, and it can cost our infrastructure quite a bit of money. What is also a little surprising is, despite knowing that heart disease accounts for almost a third of deaths in this country, is what people worry about. So if you look at our Google searches, cancer and other things are still the predominant pieces of information people are looking for. And when we look at media coverage by places like the New York Times and the Guardian, again, heart disease disproportionately is affected in the sense that it's rarely covered. You know, the AHA launched a large campaign, the Go Red campaign, and despite multiple attempts, lots of money and time, the awareness of heart disease as the #1 killer for women even went from 30% to most recently a little bit over a half. So there's still a lot of work to be done. So what is LPA? I think this is a nice pictorial looking at where LPA falls within the ApoB atherogenic particle structure. We know that it's synthesized by the liver and first discovered by, I believe it was a geneticist, right? Mm-hmm. Dr. Berg. And the reason it's distinguished from a traditional ApoB lipid molecule is it also has an ApoA component that's tethered to it. I'll show you a picture in a moment. And it's only found in the plasma of humans. And we still don't really entirely know its function or what receptors it works on. We know that it was it has evolved over time, and we suspect there may be a component of reducing bleeding that it might have been founded for. And does anyone know any other animal that it exists in? I know Sho knows, so he's not allowed to talk, but anyone else? It's the hedgehog. Cute. So going to the molecule again, so as we can see here, you've got the LDL-like particle with the ApoB, but unfortunately, LPA is even more dangerous, in my opinion, because you've got this ApoA component tethered to it via this disulfide bond, and then you also have your oxidized phospholipid. And then Josh is going to get into a little bit about these kringles and how it can determine the amount in the blood. And the one thing I want to highlight is in that kringle domain is it's very similar to plasminogen, and it actually can interfere with that pathway, which is kind of one of the reasons we think it's associated with thrombosis. So in summary, this is your LPA molecule. It has 3 pathologic components. It can be prothrombotic, largely from this, we think from this plasminogen-like ApoA structure. It can be pro-inflammatory, possibly related to this oxidized phospholipid component. And it's also atherogenic, we know from the LDL core. And we can kind of, what we know clinically we see is an increase in ischemic stroke, aortic valve stenosis, cardiovascular disease, and PAD.
I'm going to go back one slide first, but so keep in mind this disulfide bond. We'll come back to this in the end because it's now emerging as a potential therapeutic target. And before I go into my section, I also want to expound a little bit. Abha's always very modest, but the reason we're doing this is because she came and said, you know, we should really talk about LPA. We talked about LPA about 10 years ago, and And we're now on the cusp for LPA of where we were for LDL in the 1980s. In the 1980s, we knew LDL was causal for cardiovascular disease. It wasn't measured very frequently. We didn't have drug targets. We didn't have drugs that were effective in lowering it. But now we know that LPA is not only causal for all of these cardiovascular conditions, it's actually the strongest risk factor for some of them, like calcific aortic valve disease, which we'll talk about. But there's also drugs that are almost for sure going to emerge into our clinical practice over the next couple of years. So we thought it would be a really good time to educate you all. Abha has spent a lot of time she's now part of the Family Heart Foundation family. She goes around and gives talks around the country to try to educate the world. I think she wanted a media tour where she was speaking, I don't know how many news outlets you did in one day, but a lot, with the founder of the Family Heart Foundation. And she's been instrumental in trying to get us as a part of the clinical trials in the clinic for lipoprotein A lowering therapy. So shout out to Abha for that. If you want to learn more about LPA, we're having our Family Heart Foundation annual summit this weekend in Washington, D.C. Keith Ferdinand, one of Eldrin's good friends, and Gisette Reyes-Sofer, who's one of the international experts for LPA, will be the co-chairs, and I'm one of the hosts and have been for many years. So let's get into how LPA levels are determined. And this is a little bit different than LDL cholesterol levels because LPA is basically genetically determined. The level that you have at your death is the level that you have essentially at your birth. It is inherited in an autosomal codominant manner. We typically say familial hypercholesterolemia, at least traditionally, has been thought of as an autosomal dominant phenotype. That is, if you get a copy of the bad gene from mom or dad, you're going to have the phenotype. LPA levels are codominant like blood groups. So your level is determined by the additive effects of the genes that you get from mom and the genes that you get from dad. So it doesn't necessarily always follow that Mendelian inheritance pattern. You could get a good gene from mom and a good gene from dad for LPA and have normal levels. And you could get a medium gene from mom and a medium gene from dad and have very high LPA levels. So just to give you that sense. It also has a very skewed distribution in the population. This slide is from Jorge Nordesgaard, and he's one of the pioneers in LPA, and he and his wife, Ann Tiber Hansen, are actually getting the Pioneer Award at the Family Heart Foundation meeting this weekend. But one of the things he showed, or has at least demonstrated in the literature, is that it has a very skewed distribution. The vast majority of us have LPA levels less than 30 milligrams per deciliter, or and there's a different scale too, nanomoles per liter. We'll talk about that. But there's a long tail. And so some people have LPA levels 150, 160, 300, 400. And it's really that tail of the distribution that's really the highest risk. And we'll talk about that. But LPA levels are highly variable in the population. And their levels are determined essentially only by the LPA alleles that they have, the LPA genes that they have. It's not really changed by diet, by exercise. It's not changed much by drug therapy. We'll talk about that. It does rise a little bit in women after menopause, but it's really determined by your Kringle repeats. And these Kringle repeats, they're named for the Danish Kringle. These are these repeated motifs in the protein. The higher the number of Kringle repeats you have, the lower your LPA levels. The liver recognizes high number of Kringle repeats as an abnormal protein and doesn't put it into the plasma. So low Kringle repeats is a high LPA levels, and that might explain part of the reasons why there's differences in different race ethnic groups. So LPA levels, we get asked this question all the time. Don't you need to recheck my LPA level? I mean, I had my LDL level checked last year. Do I need to recheck my LPA level? And we generally don't need to do that. A person will have the same LPA level, and that's one of the reasons we can say some of the guidelines actually say we should just measure everybody's LPA at least once in their lifetime, which makes some sense. As I said, menopause lowers LPA a little bit, and you might see a 20% rise after that. And you can also see LPA, like many other lipid molecules, is an acute phase reactant. So you don't necessarily want to measure it at the time, or you have to at least know that if you measure it at the time of an MI, it might be slightly different. Okay.
How common is Lp(a) elevation? Does anyone want to take a guess? Thank you, David. That's exactly correct. And so, obviously we know that the gene evolved out of the African continent, and so there are different prevalence rates based on ethnicity, with the highest being amongst our Black population up to 1 in 3, and then subsequent to that is the South Asian cohort, which can be up to 1 in 4. So we know that there is some variance based on ethnicity, but generally speaking, 1 in 5 people have an elevated Lp(a), and that worldwide is almost 1.4 billion people. And so this is a nice sub-analysis done on the Heritage study. We were a site for Heritage where they enrolled about 48,000 people to look at the prevalence of Lp(a) in atherosclerotic disease. And what Dr. Shapiro's group did was to take a look and compared the different ethnic cohorts as well as gender. So they noticed that Black participants and female participants had a higher median Lp(a) value. So 1 in 2 Black participants had Lp(a) exceeding 125 nanomoles, and 2 in 5 female participants had an elevated Lp(a). The thing to kind of take away is there's been a lot of back and forth in the literature whether we should be kind of normalizing the Lp(a) based on ethnicity, but really what we are finding is it really doesn't matter. What matters is the absolute value. So if the Lp(a) is elevated, your risk is associated with that elevation.
So what are the risks of high Lp(a)? And I love this slide because it was taken from a review, an editorial, I think, that was written by Abha and Dan Kim. And Kim, shout out to Dan Kim. I think he must be online. But anyway, this is a beautiful figure. Dan has a talent with figures. And it really shows that it's multifactorial effects, increased cardiovascular risk. It is thought to have a pro-inflammatory effects. Oxidized phospholipids get inside the blood vessel wall and trigger this inflammatory response. It probably has prothrombotic effects. And the way that we can think about this is it turns out that LDL cholesterol is not an especially strong stroke risk factor. People with familial hypercholesterolemia paradoxically don't have a massively increased risk of stroke. However, people with high Lp(a) do. And it's one of the hypercoagulability workup. We don't really understand that entirely, but there is some similarity of the gene to parts of the plasminogen fibrin kind of cascade. It definitely has pro-atherogenic effects. It also has effects on coronary disease, obviously, and peripheral arterial disease. And again, it's the strongest known genetic risk factor for calcific aortic valve disease. And I know that Dan was even thinking about looking at that, and I've tried to encourage that as much as possible in our interventional colleagues. I think that everybody that gets an aortic valve replacement or therapy should have their Lp(a) checked. And we'll come to how often Lp(a) is checked in a minute, right? We'll presage that. You guys think about what number you think, what percentage of patients have had their Lp(a) measured, and we'll ask that in a second. But anyway, genetic studies, this is one of the first cardinal examples of how Mendelian randomization has been used to influence decisions about causality. If you're a drug company and you want to drug a target, you want to show that it's causal for the disease. You know, CRP is not causal for coronary disease. HDL is probably not causal for coronary disease. They're markers. They're biomarkers associated, but Lp(a) is causal. And one of the strongest pieces of evidence came from these Mendelian randomization studies. Again, Jorge Nordestgaard was one of the leaders in this. And the idea is pretty simple. If a genetic, if a biomarker is causally associated with a disease, is causal for disease, then the genetic markers that control that biomarker should also be causal associated with coronary disease. And that is the case for Lp(a). And again, I said those Lp(a) genetic variants, they don't influence anything except Lp(a) levels. So you can take away like pleiotropic effects and things like this. So it's a very strong, we have very strong genetic evidence that is causal for coronary heart disease, which is one of the reasons we're so excited about the therapies that are coming down the pipe. Its distribution and the risk, how high does the level have to be before you have an increased risk? And really, we say that the risk starts to increase around 50 milligrams per deciliter, and we'll show you what that means in nanomoles per liter. But really, the level, the risk starts to dramatically increase when you get 100, 150 milligrams per deciliter. And this is the geometric mean. And you can see that as they levels approach 120, 150, 200, you know, you see a markedly increased risk. This is really important because when we're thinking about developing therapies, if you're talking about a person at this side of the distribution, at the very tail of the distribution, modestly lowering their LPA is probably not going to be enough. You're probably going to have to lower LPA levels by as much as 80 or 90% to get a massive therapeutic benefit. And that has implications for the treatments we have now and for the treatments that are coming down in the future. So we can't be complacent because we know that the therapies that we have now, like PCSK9 inhibitors, which we'll talk about later, probably don't have a huge effect on people with LPA. And I'm just going to go through a few more slides about risk. So these are secondary prevention studies, a bunch of secondary prevention studies, and you have to understand a lot of these were done a long time ago, and LPA measurements were done probably in varying ways. But overall, the results hold true that if you have a high LPA, you're very likely to have problems in secondary prevention populations. In familial hypercholesterolemia populations, it's extremely bad. If you have both FH, high LDL, and high LPA, your risk is dramatically increased, and it's been shown both in the Spanish population and in the Copenhagen heart studies. And if you're a smoker, it's really bad. So one of the major things that we have to do for smokers, and we don't really understand why that is if they have a high LPA, it's almost I hate to say it's a death sentence, but it's very, very bad. There's a very strong interaction between smoking and high LPA levels.
And when you look at the plaque phenotype, it actually doesn't help that problem either. So when looking at CCTA studies,
We threw these in for you, Bill. All these plaque phenotype, we have some.
Yeah, the low attenuating plaque here, when we looked at plaque progression over 12 months, you can see that in patients with LPA compared to placebo, the LPA cohort has more plaque progression. And then again, specifically for Bill and my cath lab friends, they've done pullback studies in patients with acute MI, and they've looked at non-culprit plaque TICFA, and they've noticed that patients with elevated Lp(a) have more of this thin cap fibroatheroma. And then when talking about patients that do come to the cath lab, I really do want you all to think about this. There is an increased risk for repeat PCI and mortality in individuals that are getting stents. So I don't know how often you guys are checking, but it's really worth it, if nothing else, prognostically, to have an idea for these patients. And then we keep coming back to aortic valve stenosis, and that's largely because we're going to talk to you about a trial we're doing. But we know that looking at the Copenhagen heart study, that the risk of aortic valve stenosis increases with the increasing value of the Lp(a), both age-adjusted and multivariate adjusted. And then when we talk about what is normal for LPA, there is some difference based on which guidelines you use, but the AHA and the ACC consider an elevated Lp(a) to be 50 milligrams per deciliter or 125 nanomoles, but the NLA has a slightly lower threshold. And so when talking about who and when and how it should be measured, I'm going to again tell you a little bit about the heterogeneity here. Back in 2018, the ACC-AHA gave guidance on what is a normal threshold, what's an abnormal threshold, but really didn't give any guidance for who should be screened. Subsequent to that, the NLA came out with guidelines saying that, intermediate and high-risk patients, it's appropriate to screen, and that the LPA value threshold was a little bit lower. After that, our Canadian friends looked at guidance, and they kind of made a bold statement saying that everyone should be screened at least once in their lifetime as a part of kind of risk assessment, and their thresholds remain 50 and 100 nanomoles. But most recently, which I personally think this is the right thing to do, is the European guidelines noted that all adults should be screened and gave the thresholds of 50 and 125.
Ask the 1%.
Yeah, I am.
Yeah,
don't worry. I know you're excited.
I know, I'm excited about that one. Okay.
And then just, we know, Josh already mentioned this, that those that have extremely high Lp(a)s have almost a similar risk to ASCVD as FH. So, we're really learning a lot from the FH population and applying it to the LPA population. And so, why should we measure LPA? I think we've already kind of made the case, but I'm going to just repeat myself here. We know that it's a causal risk factor for heart disease, stroke, and aortic stenosis. It's the most common inherited dyslipidemia. It's genetic. You know, it's something that you can't necessarily influence with diet and lifestyle, so it's worth knowing. And I do think it adds additional information beyond just this traditional lipid panel. And most importantly, things like what Sho's doing in his clinic, it's the potential for early intervention. If we can screen and cascade screen these individuals, we potentially have a very cost-effective way to reduce the disease course. And obviously, I'm very passionate about having patient awareness. I think that though we don't have therapies yet for LPA, if we can get to these patients early, maybe they can modify their other risk factors while we're waiting for some of these drugs to come to market. And then now Josh wanted to ask.
And I think the other thing is we don't have specific therapies for LPA, but there's very good evidence that if we lower LDL cholesterol very substantially, we can greatly offset that. So we can push therapies harder in these populations. But I'm going to pick on the fellows. So how many people have had their LPA measured? Just you're going to go through each of you guys. What is your guess?
Percent. Give us a percent in the US.
1%. 2%. This is like a Price is Right. You can't go over, right? Okay. 0.5. 0.5. Okay. Yeah, you guys are all right. You must have gone to some of my lectures before because it's about, we have very smart fellows. It's about 1% of the population. So I bet if I had asked our faculty members, they would have been like 25% or something like that. But anyway, 1%, less than 1% have had their LPA measured. And this is a big potential lost opportunity for prevention.
I just want to put a plug out there that the cost of an LPA is less than that of a mammogram. I mean, it's a very low cost screening tool for a very prevalent disease. There are now companies that will do pay patients can get their own LPA test for like $25 or something. Anyway, okay. I'm talking about this. Okay, so the LPA assays. This has been an evolving field for the last 30 years. You can imagine that if you were to develop an assay that determined LPA levels by the number of Kringle repeats that were present in the plasma, that would not be necessarily the right thing to do because people with high number of Kringle repeats, you get potentially false results. So now the field has moved towards and has largely supplanted those old inaccurate assays with isoform independent assays, which are really now the standard of care and are being used all around the country. And so you should feel pretty good that if you send an LPA off, that you're going to get an accurate assessment of their LPA levels. Again, the milligrams per deciliter or nanomoles per liter we'll talk about on the next slide. But you should be confident that a high LPA in one is also going to show a high LPA on the other in general. Most big labs around the country are starting to move towards interpreting LPA using assays where they report nanomoles per liter. Our lab at Stanford still reports milligrams per deciliter. It's not a reason not to do it. It can still be interpreted. And we hope that over the next few years that there'll be consensus reached and we'll all kind of get very standardized about that. Now, one of the problems that the Family Heart Foundation has is we're a big patient advocacy organization. And in some parts, we're a little bit of a bubble here, and we all document really well. And so we haven't had as big a problem with this. But many parts of the country, insurance companies are not paying for lipoprotein A tests. And so that's a big burden. If your physician says you should really have this, and then the insurance company says we're not going to pay for it, well, then you're in a conundrum. And so clear documentation is needed. There are LPA-specific ICD-10 codes. I think I actually advised the prior LPA Foundation on how to get this, but it's really important to potentially document the reasons that you're doing this, ASCVD or subclinical atherosclerosis or other things that fit with the idea that it's a risk-enhancing modifier and recommended in certain situations by our guidelines. So how do we treat high LPA now and in the future? And this is something that's really important. And even though this is a genetic condition, I think we have to understand that genetics does not equal destiny. I stole this slide from Amit Kara, who's now at Verve, but was at Broad, for instance. And this is not specific for LPA, but it holds in general that you can greatly offset your polygenic risk or your FH risk, your high LPA risk, any kind of genetic risk you have, you can greatly offset it
with very favorable lifestyle choices, diet, exercise, non-smoking, maintaining your blood pressure, all those things massively offset your genetic risk. So how do we do that for high lipoprotein A? One is you control your other cardiovascular risk factors especially well, especially your LDL cholesterol. Many of us actually kind of move the needle for LDL down one level. So, for instead of primary prevention, high LPA, we might say primary prevention less than 70 for LDL. That's one trick. And there's some decent evidence that might be a good idea. In the familial atherosclerosis treatment study, if you had extremely high LPA and you had your LDL low, you offset a lot of the risk from the high LPA. And there's other studies that are emerging about this. Again, there's very good therapies that are in phase 3 clinical trials right now. We don't have a drug that specifically lowers LPA massively. PCSK9 inhibitors lower it by about 15%, and sometimes that can shade you to a PCSK9 inhibitor in certain situations, but they're not approved for LPA reduction. You're going to go. Yeah.
I mean, so as Josh was saying, diet has no impact, and we know in the past people used to use niacin, which can have up to a 20% reduction, but we know that it has its own consequences. And with statins, we know it can actually raise LPA values slightly. With ezetimibe or bempedoic acid, there's really no effect. We talked about PCSK9 inhibitors. We know that with estrogen, we can lower it about 10 to 15%. And then there is apheresis available in the community that patients can go to every 2 weeks to have their LPA reduced. And on average, it'll reduce it about 30 to 35%. With regards to estrogen, though we know it decreases the LPA values a little bit, but we have multiple studies now showing that hormone replacement therapy actually increases adverse events like breast cancer and thrombosis, as well as stroke. So it is not routinely recommended to lower LPA. And with niacin, I think we all know that it can increase your blood sugar. There are GI side effects and risk of gout. So it's really not a hugely beneficial drug in this arena as well. With PCSK9 inhibitors, both evolocumab and alirocumab can reduce it. We've had studies from the 4A and Odyssey trial. You guys are all familiar with it. And we saw that LPA reduction was partly responsible for the reduction in cardiovascular events in these studies. But as we know, PCSK9 inhibitors are not FDA approved for LPA reduction. And we're actually going to go back to kind of what Josh was talking about earlier, is we do have drugs in the pipeline. So we've been sites for a couple of these drugs, and we're part of the phase 2 and now phase 3 studies for these RNA antisense therapies. So pelacarsen is the one that's probably most mature, and we've closed enrollment for that study looking at cardiovascular outcomes, and it's been developed by Novartis. In the phase 2 trials, we saw almost an 80 to 85% reduction in LPA values with this medication. Alpaceran is in phase 3 trials right now. We're hoping to be part of this study. And it also works through the RNA mechanism, and it's by Amgen. And then there's some earlier in the market by Silence Therapeutic. The difference in mechanisms of action, Josh will get to in a moment. But if any of these actually turn out to reduce cardiovascular outcomes, we could see them on the market in the next several years.
The companies are they're being very economically conscious. These trials are usually enrolling patients with secondary prevention, especially. I think they're exclusively secondary prevention. You have to have a pretty high LPA level. And at least in the trial that we started, so if you're thinking about sending patients, to us, please ask us. But they usually didn't even allow stent placement as an indication for stable angina. It was usually they had to have a heart event, stroke, myocardial infarction. So patients are always asking, can I get in that LPA trial? And if they're for primary prevention, it's very unlikely to be the case, because they're going to target very, very high risk patients initially, because they want to do a short trial and get the drugs on the market quickly. And
actually, for the newer studies, they've actually removed stroke and PAD as an indication. So they're only looking at the ACS patients and largely enrolling abroad.
So this is a very old slide. I'm not going to go greatly into the mechanism, but I will preview this. I'll preview, give a shout out to Kevin Alexander and Vicky Parikh, and I think me, because we're coming back in a few months to give a talk on genetic therapies and other therapies for reducing cardiovascular risk across many domains, and there's some exciting stuff coming in that line. But in some ways, some people even consider this gene therapy because the therapies work by inhibiting the transcriptional mechanism, for LPA, and so LPA doesn't actually even get produced, and these therapies can be injected a couple of times a year often, and they dramatically lower LPA. This is an old slide. Before Ionis was ISIS, and then they were Ionis, and now they're Axia, and whatever. So they've changed their name several times, but this is one of their early drugs, and it's been very effective. Hot off the press is a paper that came out just, I think, last week from some leading lipid specialists, Steve Nichols and many of the other colleagues, have an oral small molecule inhibitor, and this molecule actually goes to this disulfide bond, like we talked about, this disulfide bond, and it kind of inhibits that disulfide bond formation, or kind of, and so it does not allow the tethering of the ApoA to the ApoB containing lipoprotein, and that has also shown some promise. But to be honest, when I saw this paper, we thought it was apelin, which has been studied by many people at Stanford, but then we realized it was is not the same compound. So another thing that we get asked about, or one other thing to consider about lipoprotein A, is should we have a lower threshold for using aspirin for people with high LPA in primary prevention? And there's some decent evidence that we should. Aspirin has not been shown to be that useful in people for primary prevention in these very large studies that came out a few years ago. But subset analyses of some of these trials has shown that if you have very high LPA, that might be one of the subsets that benefits from aspirin. And actually, these data have now been replicated by Pradeep Natarajan and others, showing that people that carry the risk alleles probably benefit from aspirin, and those data are emerging. So we do have a lower threshold for aspirin use in primary prevention if LPA levels are very high, especially if there's subclinical coronary disease. So now I'm going to talk a little bit about can we identify people with high LPA before they become patients with high LPA? And I think this is really critical. When you think about a condition where it's very high risk, it's genetic, there are potentially effective therapies, but less than 1% of the population has had it measured, we're not going to immediately turn a crank and get 50% of the population to have LPA measured. We're going to have to use hook or crook or whatever to try to change the needle a little bit. And we're kind of approaching this, or many people are approaching this in different ways. And so, Abha, you want to talk about this one first?
I mean, just brief. I think the FIND-FH. We're potentially, the AHA is getting involved in looking at large get with the guidelines type registries to try to help document LPA in some of these larger cohorts. And the goal is the same, is to identify these patients, start mapping a process to identify these patients. And I think they're getting ready for potential therapies that will be coming down the pipeline. But I think Josh is going to talk a little bit about what we'll be doing at Stanford, hopefully.
So a few years ago, many of you guys are aware, we did this project called FIND-FH through the Family Heart Foundation. The idea was I couldn't go to the medical record and get all the people that had an ICD-10 code for FH because it didn't exist prior to our application for an ICD-10. So we collaborated with Nigam Shah and the Family Heart Foundation, and we created a machine learning algorithm. At the time, I think there was less than 200 papers in the medical literature about using machine learning or AI in medicine. This was several years ago now, and we showed that we could develop an algorithm to find familial hypercholesterolemia patients with high accuracy, and many of these patients didn't even have a lipid panel. So that has brought the Family Heart Foundation to the idea that maybe we can turn the crank again. Maybe we can develop a machine learning algorithm to identify patients that are likely to have high LPA, to drive testing, to drive treatment, to drive better outcomes for those patients. And we're building on all the learnings that we did with the FIND-FH process, where we developed this algorithm. Now, the caveat to this, as always, is it actually turns out that in the whole process of using machine learning or AI in medicine, it's not the development of the algorithm that's the problem. Developing the algorithm in the grand scheme of things nowadays is fairly trivial. It's actually how do you implement processes at healthcare systems to try to change the whole way that we deliver care to incorporate this information in ways that are meaningful. And the Family Heart Foundation has done a really good job. We're going to be part of this at Stanford, where there's already some sites that are active, and they're helping actually to engage patients at these sites. They're identifying patients with familial hypercholesterolemia likely. They're helping the clinicians and others in healthcare systems to identify these patients and drive them to actually take their therapies and use cascade screening. And we're going to do the same thing for LPA. We're going to have this Find LPA program. I think actually there's an announcement yesterday that program has now launched, and we hope to be a site for that as well. And so keep in mind this is coming in the future to a site near you. So, I think we have tried to show that we need to give patients hope that have high LPA. Our clinics are filled with patients with high LPA. I think probably in the prevention clinic and the interventional clinics. Your clinics are also filled with patients with high LPA. You just might not know it yet, but you will soon after this talk. So, and the idea is that we're going to do the same thing for LPA as we've done for FH. So I showed this slide a few years ago at our summit. In 2012, there was less than 1% had been diagnosed with FH and LPA. There were no ICD-10 codes. There was no national registries. There was no awareness days. We had our last FH awareness day last weekend. We usually reach tens of millions of people via the platform formerly known as Twitter and other social media platforms. There was no information for patients that could be easily accessible, no guidelines. It was not in the guidelines. There's no specific shout out to LPA or FH. There's no constituency advocating it. There's little funding. And now in 2023, we can say that 15% of people we think have at least an ICD-10 code for FH that we created, and those have now been approved for LPA as well. We have over 6,000 patients with familial hypercholesterolemia enrolled in this registry, and similar ideas are being done for lipoprotein A. There's a FH and LPA awareness day. Like I said, reaching over 20 million people last year. I don't have the statistics for this year yet. There's a growing community with hundreds of FH and high LPA advocates that they come and they learn about their condition, how to communicate that with their family members and their senators and their congressmen. There's 50,000 visitors to our website a month. There's a genetic testing statement, et cetera. There's innovative treatments. We're kind of in a golden age of lipid lowering therapy. For many years we had statins and that was it, and bile acid binding resins, and then we had ezetimibe, and then we had PCSK9 inhibitors, and then we had inclisiran, and now we're going to have LPA lowering therapies, bempedoic acid. So I think we should have a lot of hope, and even for patients with calcific aortic valve disease.
Yeah, and I just want to point out that Josh is also extremely humble. A lot of the progress that has been made in the field has largely been from his tireless efforts. So I'm very lucky to have him here with us. And so we are going to be starting a trial for Lp(a) with calcific aortic valve disease. We know that already in the literature, there's about 20 plus studies showing the association, and they include prospective studies, genome-wide association studies, and Mendelian randomization studies. The one that we'll be participating in is the same compound that we used for the ASCVD outcomes trial, which is CTQJ230, also known as pelacarsen. It'll be monthly injections for, again, individuals with very high Lp(a), and we'll be looking at the aortic velocities between 2.5 and 3.5 meters per second, and then following these individuals for 36 months. We'll be looking at echo parameters at yearly intervals, and then also CT data both at baseline and at the end of the study to try to understand the calcifications. The primary endpoint will be trying to slow the progression of calcific aortic valve disease. And so there are some secondary outcomes looking at kind of plaque composition and LPA lowering.